Assalamu alaikum. Good morning, everyone, here in Babylon, Iraq, and to friends in Ireland. It's my distinct pleasure to welcome you all to the fourth webinar of its kind between international renowned pediatric experts and the pediatric unit at Imam Sadik Hospital, headed by Dr. Iyad Al Khazraji here in Hilla. I want to extend a special welcome to our distinguished guests, Dr. Hussein, Muhaibis Al Hasnawi, and Dr. Zahir, Ghanim, who is the lead pediatric pulmonologist here in Babylon, and also to you, the distinguished speaker, Dr. Aamir Qais, who specializes in pediatric respiratory medicine and who is based in Ireland. We are also waiting for a distinguished guest, Dr. Salih Baee, who is an adult pulmonologist, also to attend here. We are gathered here today to explore the management of asthma in pediatrics from an Irish perspective, a topic of critical importance to our field here in Iraq. I would like to express my sincere gratitude to Dr. Ammar Saeed and Dr. Iyad and Abdullah Alnaseawi for their tireless efforts in bringing this webinar to fruition. I am confident that these webinars will provide valuable insights for all of us, whether specialists or trainees, to learn and grow professionally. I encourage you to actively participate, engage with your speaker, and make the most of this enriching experience. I wish you all a productive and inspiring webinar. I leave the air to you, Dr. Qais, Aamir Qais.
Assalamu alaikum, Ikhwan. I'm really delighted to be with you today for this opportunity to share the expertise, local expertise, and hopefully we can work together for the benefit of Iraqi children, which is my home country. I'll try. Asthma itself is a very big subject. Now, one small lecture, it won't be enough, but I try to address all the suggestions from Dr. Iyad requested for certain things. And please, even after the lecture, I would be happy to just text me or send me any request for articles, guidelines, helps. At the end of the day, it's for benefit of the patients. So feel free. So we'll go for a simple and short introduction, then diagnosis of asthma in children below 5 years old, and then we'll go to the management for the same cohort, challenges in the management of severe asthma, then the differential diagnosis of severe asthma, whether is it the right or wrong diagnosis, comorbidities, severe or steroid therapy resistant asthma, and the last thing is the updates in the management of asthma. So defining asthma, it's evolving definition, and it's and you can find it defined in different ways in different areas, different articles. But the simple way is asthma is a chronic inflammation or inflammatory disease characterized by a reversible airway obstruction and bronchospasm. Now, most of the time, this exacerbation is precipitated by viral infection. Recurrent wheezes occur in large proportion in children 5 years and younger. Now, defining or deciding that this is the first asthmatic attack is very difficult. Now, I try to look for some statistics data from Iraq about the incidence of asthma. And it's I found some articles from Baghdad, from Basra, but overall the incidence was around 20%. Now, going to the first thing, diagnostic criteria. Now, diagnosing asthma in the cohort of children below 5 years old is very difficult. It's not an easy, and there are no specific tools for that, but rather than it will be a clinical one. And this is applicable in the UK and Ireland. And so the UK guidelines, the Irish guidelines, depending basically on something called GINA guidelines. I think you heard about it, which is a global initiative of asthma management. And there is updated one for 2025. So in order to diagnose asthma in children below 5 years old, we will have this recurrent acute episodes wheezy episodes, or one episode of acute wheezes with asthma-like symptoms like coughing during episodes of crying, laughing, or even night cough. So this is mandatory. The second point is there should be no other walk-in diagnoses like acute bronchiolitis, congenital anomalies, or other differentials. And the third or the last point is the timely clinical response to asthma treatment demonstrated by at least one of the following points. The first one is rapid symptoms improvement within minutes after administering beta-2 agonist, which is the salbutamol, during acute wheeze, whether in the setting of hospital or at home, or severe symptoms resolution after 3 to 4 hours and the setup of hospital after giving the short beta-2 agonist in terms of nebulizers as well as the oral corticosteroids. Now, the second point is reduction in the severity or the frequency of acute wheezing episodes upon starting trial of using inhaled corticosteroids in 2 to 3 months' time, and then upon stopping the medication, the symptoms recur or the frequency recurs. Now, two other considerations for here. If a child meets only 1 or 2 points of the above criteria, the correct label will be suspected asthma, and in this way, those children needs to be followed for 6 months or for 1 year to make sure that our diagnosis is the right one, or it's just viral-induced wheeze, because there is a high percentage of higher frequent wheeze, especially below 3 years old. The second consideration, a personal or family history of allergic disease may strengthen the diagnosis, but it's not specific. Now, this is a diagram of stepwise management for the children 5 years and younger. And we can see it's basically the circle. It's the basic for asthma management, which is review, assess, and adjust. So we can see the first steps. Basically, if you got a patient, infrequent acute wheezy episodes and or minimal interval symptoms. So the consideration here to start on intermittent inhaled corticosteroids. So the previous days we were using the salbutamol inhaler were required for query cases, but this is not applicable anymore. So we have to use short courses of ICS. So suppose the patient will have acute viral illness, we can use this like beclomethasone or flexitide. That's according to the age. We will mention this later on. For 2 doses a day, for 4 days or for 5 days, and so on. Now, if this progressed by, and you follow the patient after a while, and he's requiring frequent short courses of inhaled corticosteroids, or his symptoms are not controlled, definitely in this way we will step up to number 2, which include daily regular doses of inhaled corticosteroids. Or sometimes there will be difficulty in starting those inhaled steroids because of the compliance of the parents, or the child won't accept the leukotriene antagonist, which is the montelukast, is another choice to use it regularly. Then the next step, which is step 3 and step 4, will be going up according to the asthma controls. If not controlled, we have to go to the next step. If controlled for at least 3 months, we have to step down. Now, stepping up, stepping down usually will be within like 6 to 8 weeks. So whenever see patients with symptoms, try to assess after 6 to 8 weeks. And if the symptoms control, you can keep on the same medications or step up or step down. Now, this is very handy tool during the visits. It's just to see or if the patients have a well-controlled asthma, partially controlled asthma, or uncontrolled asthma. It's basically 4 simple questions, whether there are daily symptoms more than twice a week, any night symptoms, night cough, the requirement for short-acting beta-2 agonist per week, it should be more than 2. If so, this is will be counted as 1, and any limitation in the physical activities, and this is counted as. So if you have a total of 0, this is perfect. You mean your patient is controlled. If 1 to 2, and you in this way is partly controlled or partially controlled. So partially controlled or uncontrolled, it's suggested to adjust the treatment. So stepping up or adding adjunct treatment. Now, going to the medications, beclomethasone is the first one. It's let's say from the first generation of steroid, and can be used below 1-year-old. You can start by 50 mic per puff, 2 puffs 2 times a day, and then they go into the Flexitide. The Flexitide is Flexitide and budesonide. Both of them are second generation steroid. The Flexitide is fluorinated steroids. Suppose if you're giving a patient beclomethasone dose of 100 mic per day, 2 times a day. So if you want to switch to Flexitide, it should be at the starting point the same dose, 100 mic per 2 times a day, and so on. Why? Because 100 mic of Flexitide, it's equal to 200 mics of beclomethasone. So when you're switching a patient from a dose of 100 mic of beclomethasone to Flexitide, keeping on the same dose, which is 100 mic, you're doubling the dose. So you can start from there, and then you can decide about stepping up, increasing the dose, or adding adjunct. Budesonide is another one, but most of the time there is no inhaler. So it's basically just nebulizers, and nebulizers are forbidden to be used in children. And overall, in the management of asthma. And even in the acute setup, I know most of the hospitals across the globe, they use the salbutamol nebulizer, but lots of studies prove that using of salbutamol in a mild to moderate asthma exacerbation, using the inhaler is totally equal to the effect of using salbutamol nebulizer. But in severe case, because of the shortness of breath, we may use the nebulizer to get more benefit. Now, going to the Seretide, which is a mixture of Flexitide and salmeterol. This can be used from 4 years onward. The Symbicort, unfortunately, it's not available in the form of NDI, metered dose inhaler. It's just like powder dose inhaler. So we need a significant coordination, and you can use it with a spacer. So it can be used from 6 years onward, and the techniques is very important in deciding the right combination, right device. The Flotiform is a combination of Flexitide and formoterol, and this can be used from 5 years onward. And the last thing, which is not steroid, the montelukast, which is a leukotriene antagonist. You can start it from below 1 year. 4 milligrams till 6 years, you can update those to 5 milligrams. Till 15 years, you can update it to 10 milligrams. Now, going to the subject of severe asthma and the differential diagnosis of management of severe asthma. So we can define a patient or a child with a severe asthma depending on a few things. So first, this child should be on a high dose of inhaled corticosteroids, and there are tables available in the GINA guidelines, or even in the lots of guidelines stating this is a mild dose, this moderate dose, and this high dose. So regardless, the steroids is basically on a high inhaled steroids plus second controller like montelukast, or in older children, theophylline, plus one of the following points. The previous admission to the ICU, regular visits like 2 or more to the ED, or hospitalization 1 or more within the last year, persistent obstruction on spirometry defined as forced expiratory volume first second and or forced expiratory volume over forced vital capacity below the lower limit of predicted normal. Frequent oral steroid courses like more than 3 per year, the need for chronic oral steroid therapy, and the last important point, be aware of a patient coming to you requiring frequent doses of salbutamol and he completed 6 canisters or more per year. This is a red flag. Now, going to the introduction and the differential diagnosis of asthma. So, first one, is it the right diagnosis or something else? Now, there should be red flags. We have to get attention to those in order to, like if you have a patient with asthma, you reach high dose, no control. So think out of the box and try to get the differential diagnosis to be sure that you won't miss anything. Like with multiple episodes of pneumonia, chronic wet cough, digital clubbing, chronic rhinorrhea or sinus infection. Here, like we raised the suspicion of suppurative lung disease. So whether this is immune deficiency, cystic fibrosis, and primary cellular dyskinesia, or something else. So family history of male sterility, poor growth and low body mass index, cough or choking episodes while feeding, sudden onset of symptoms, sometimes especially in the cohort below 5 years old and especially below 3 years old, choking with the nuts or choking with the toy, and the parents won't be aware. The child will develop cough, and then in the long run there will be productive cough, and sometimes will present with the unilateral wheezy episodes, or even bilateral will be misdiagnosed most of the time as asthma, but at the end of the day, it's not asthma, it needs further intervention. Teenage onset with a prior asthma history raise the suspicion of vocal cord dysfunction, and we will talk about this later on. Symptoms since birth, which may relate to laryngomalacia, tracheomalacia, history of intubation with a suspicion of subglottic stenosis, history of prematurity, age below 3 years old, virus associated with wheezing, cough that absent at night, although it's very rare, but it can happen, which is habitual cough. Going to the next point, comorbidities. We're having a list of comorbidities, as you know. First one is exercise-induced laryngeal obstruction, and this missed most of the time with the asthma-induced exercise. So commonly it's coexist with asthma, and it's due to inappropriate closure of the larynx during exercise. Symptoms usually occur during the exercise rather than at the end of the exercise, unresponsive to beta-2 or inhaled steroids. Now, how to differentiate exercise-induced laryngeal obstruction from exercise-induced asthma? So first, in the exercise-induced asthma, there's no structural abnormalities, and the psychological factors predominate. Most of the time, there will be some structural disorders, and the exercise-induced laryngeal obstruction, like previous laryngomalacia or recurrent laryngeal nerve palsy. And sometimes it will be indeterminate pathology. Now, management-wise, diagnosis by suspicion from collecting the history. Second thing, using the video to tackle the things like showing the symptoms of acute stridor rather than wheezes, and it's happening during the exercise. If you're in doubt, in this way, you need to do a laryngoscope, so during exercise. Second point, the obesity. Now, the obesity is evolving across the globe, and the mechanism of having bronchospasm here, it can happen in different ways. It's not just simple as asthmatic patient or allergic asthma. The first way, which is through the mechanism of fixed airway obstruction, we call it dysynapsis. And dysynapsis, simply, we can define it as in a proportion lung growth. So the lung will grow in a certain rate and the airways will grow in a lower rate, and there will be disproportion and small airways, and this will lead to the fixed airflow obstruction. So this can happen mostly in early childhood, especially in low birth weight with excessive weight gain. So this can happen. The second mechanism is variable airway obstruction, just like other asthmatic, by having a smooth muscle constriction and atelectasis. The third way is having inflammation, whether eosinophilic, neutrophilic cells will be involved. And the last way, by having infection, because of there is disturbance in their microbiome. Rhinosinusitis, most of you treated those asthma patients, and if you don't control nasal allergy, you can't win the battle. So symptoms are sufficiently debilitating. Evidence that of treatment of the rhinosinusitis definitely will improve the asthma control. Avoiding allergen and health steroid, antihistamine, and leukotriene antagonist modalities to treat the rhinosinusitis. Gastroesophageal reflux disease, again, is another comorbidity which can coexist with asthma in the same patient. PPI and lifestyle change is the management plan. Next point is bronchopulmonary aspergillosis. So if you're in doubt or suspecting that, so we have to do a couple of tests like total IgE, and IgG for Aspergillus fumigatus and CT chest. And the treatment will be using either the steroids or antifungal. The last one is the psychosocial morbidity. So when dealing with a child with asthma and psychosocial issues, we have to get attention which one led to the other one. Sometimes, because of the asthma as a chronic disease, can have some psychosocial consequences, and sometimes some psychosocial conditions will end up by having asthma symptoms. The presence of both must be acknowledged, as simple as that, and both sides should be addressed. Now, going to the next point, need to get to the basics, right? Did we miss something in the management? So here we have, and we should stick to those points during each visit. So it's basically looking to the technique of using the inhaler by using the right spacer or not. And even we suggest to use a spacer with the face mask up to 3 years, and then, up to 5 years. And from 5 years, you switch to a mask with a mouthpiece. Now, going to the environment, whether parents are smokers, they do have pets, especially what I heard like recently, like for the last few years, in Iraq, is the pets are evolving in houses, and the air pollution, the allergen exposure. So all those are triggering points, and the adherence or the compliance with the medication. Now, the magic word here, I can say it's team. So team stands for technique, environment, adherence, and medicine. So this should be checked in each visit. Going to the next point, which is severe therapy-resistant asthma or steroid therapy-resistant asthma. So currently, no, not one size fitting all people. So as simple as that. So treating asthma, there are two evolving types of endotype. It's basically, previously we were calling type 2 and non-type 2. And recently this nomenclature changed to type 2 high and type 2 low, depending on the cells and cytokines involved in the mechanism. So type 2 high asthma is typically of atopic patients. It's characterized by high sputum, more than 4%, blood eosinophils, more than 300 per microliter, and high FeNO level more than 25 parts per billion. The cytokines involved here, interleukin 4, 5, and 13, those will be produced after allergy in exposure. And there is the interleukin 33 and 25 and thymic stromal lipoprotein. Those will be activated upon exposure to viruses and bacteria. Usually this endotype will cover more than 50% of asthma patients. Currently, there are 5 monoclonal antibodies used in the therapy of this severe asthma, especially at the end, because basically we have to start with the steroids and try adjuvant treatment. If not controlled, there are other modalities. And separate consideration will be paid for the use of those monoclonal antibodies according to the age, degree of eosinophilia, IgE levels, presence of comorbidities, frequency, the route of administration. All this must be considered. Now, this diagram, I think all of you are familiar with. It's basically so upon exposure to allergens, viruses, or bacteria, there will be the trigger of those interleukins 25, 33, and thymic stromal lipoprotein, and each one will work on different cells. So interleukin 4 will go through the stimulation of B cells and then mast cells to produce IgE, and then from innate lymphocytes type 2 will lead to the secretion of interleukin 5, and this will stimulate the chemotaxis of eosinophils, which involve in the mechanism of allergy. And you can see here through interleukin 13, we will the system or any asthmatic will start producing increasing amount of nitric oxide, which can be detected through FeNO test level. Going to the options available, there are 6 types of biologics available at the moment. Each one works at certain age and certain applications. So to start with, the omalizumab, it's anti-IgE, can be used for children more than or 6 years old and onward with a moderate to severe allergic asthma, incomplete control, positive allergy testing for IgE of 30 up to 1,500. Mepolizumab is another biologics work on anti-interleukin number 5. Again, can be used from 6 years onward for refractory severe eosinophilic asthma. Reslizumab, another anti-interleukin 5, can be used from 12 years with a severe eosinophilic asthma. Benralizumab is another anti-interleukin A. It's one of the receptors. So subgroups of interleukin 5 can be used from 12 years with severe eosinophilic asthma. Dupilumab, which is anti-interleukin 4R, which is again a sort of receptor, and again can be used from 6 years onward with refractory eosinophilic asthma. The last one is tezepelumab, is a human monoclonal antibody, binds the thymic stromal lipoprotein and blocks from interacting with high affinity to the receptor. And it's basically this can be used from 12 years onward. Now, the good thing with the tezepelumab, it can be used for both types of endotypes of asthma, whether T2 high or T2 low. So in severe asthma, regardless the endotype, this can be used for both. Now, what's the benefit of the biologics? So first, we'll lower the risk for eosinophilic asthma and the allergy part, and allow the people to stop the systemic steroid if they are consistently on steroid or having a frequent oral doses of steroids. And definitely this will reflect it on lowering the level of the risk of side effects. Helping people to reduce their exacerbations and the risk of their asthmatic attacks. Now, as an example, the omalizumab, so it works by reducing the amount of the IgE in the body. IgE, when produced in a high amount, will lead to inflammation. Can be used in cases of rhinosinusitis with nasal polyp. And it's the important point, those medications will be adjuvant. So we have to continue with our inhaled corticosteroids or inhaled corticosteroids combination with short-acting or long-acting or other things, plus those medication. And again, we mentioned previously, can be used from 6 years onward. How to give it? Usually you will do the assessment, and it's basically you have to do testing for pulmonary function test, definitely not for children below 5 years, because we don't have any tools to test here, but it's basically from 6 years onward. So, and this way you have the facility of doing the spirometry to get the forced expiratory volume per second and the ratio of forced expiratory per second over the forced vital capacity, to test the FeNO if available, and to do testing for FBC, looking for eosinophilia and the total IgE. And sometimes if your patient is allergic, you have to do skin prick testing or even a list of testing of IgE specific aeroallergens like for house dust mite, mixed grass, tree pollens, and so on. And usually it can be used 2 to 4 weeks. So you will start with a plan to be used a 4-weekly injection, but if the patient is not responding, so you have to adjust to 2-weekly or 3-weekly, depends on the response. And then you continue on previous medications, and you know the indication that the patient on high dose, continuous steroid or frequent steroids will be used. So those are the indications, and there is definitely airflow obstruction, having multiple wake up at night, frequent daytime symptoms, and just like we mentioned earlier, that we have to do some skin prick testing if we are suspecting some allergies. Now, this medicine can be used for the current guidelines and current practice. There is no suggestion to stop those medications unless they are not working after 4 months of use. So you will use for 12 to 16 weeks. And then you will decide if there is improvement, you will definitely to continue on that. And if there is no response, definitely you have to stop or try different type
Sir, I'm sorry for interrupting you. How much does it cost in Ireland, this form of treatment? What is the cost of this treatment for 4 months?
Yeah, in Ireland is actually it's all covered by the HSC, which is the patient will take it for free. But as a cost for the injection, there is the 75 milligram and there is the 150. For the 75, it will cost around 200 euros, and for this, for the 150 will cost around 350 euros. It's around this figure, maybe a little bit less, little bit up, but in the hospital, the patients won't pay anything, at least for the time being. Now, and yes, please.
Continue.
Yeah, so the next point, our next modalities in the management of severe asthma, especially the allergic asthma, is the immune therapy. So the immune therapy is it's either sublingual or subcutaneous immune therapy. And this is basically if you have a severe asthma with background of having a severe house dust mite, mixed grass, tree pollen allergies. So there are currently immune therapy option which can be used, especially the sublingual one is easy to use, no need for an injection, and the patient you do the first testing at the beginning and you do observe the first dose should be administered in the hospital setting just in case they will develop any reaction. If safe, you can continue with that, and usually you have to continue for 3 years, and upon stopping after that, usually the response will be maintained for 2 to 3 years. This is the latest things. So that's why we're using this option in certain patients, and it's really effective. Now, going to the next type, which is type 2 low asthma, is defined by neutrophilic and polygranulocytic as opposite to the eosinophilic. And usually those will be poorly responsive to these corticosteroids. For those patients, only a few strategies are available, like long-acting anticholinergic bronchodilator, theophylline, and macrolide. So tiotropium is one of the long-acting bronchodilator, can be used from 6 years onward. The theophylline, most of you use the theophylline as can be used as one of the bronchodilators as anti-inflammatory, and it will improve the steroid sensitivity and promotes the neutrophil apoptosis. So it's so beneficial in management of neutrophilic asthma. And the macrolide, especially the azithromycin, it can be used as anti-inflammatory in severe cases, refractory cases. So keeping the original inhaled steroids or other medications and starting the azithromycin 3 times a day, low dose, this will achieve the top-up control of the asthma symptoms. Now, take-home message, it's simple and easy. So first one, get to the basics, write things which is team, don't forget. So it will summarize everything on each visit, and need for MDT clinic to manage patients with the severe asthma. And remember all the time, you still have other options like the biologics and the immune therapy to be used in the management of severe asthma. Thank you so much for your attention, and I'm ready for any question.
Thank you very much, Dr. Aamir Qais, for sharing your expertise with us. As I said, today we have 2 distinguished guests here, the lead adult pulmonologist here in Babylon, Dr. Salih Baee, and the lead child pediatric pulmonologist, Dr. Zahir Ghanim.
Thank you so much, Dr. Aamir, for nice subject. وحقيقة أنا حاب أحكيك بالعراقي، أفضل اللهجة العراقية.
عادي تفضل.
الله يحفظك ويسلمك. حقيقة يعني احنا يعني عندنا فعاليات كثيرة، خصوصا الأسابيع الراحت على الجينا جايد لاينز والابديتنج about جينا جايد لاينز والdiagnosis of pediatric asthma below 5 years، وكان لنا فعاليات كثيرة. دائما السؤال اللي دائما ينطرح انه موضوع الايدنج تولز بالdiagnosis below 5 years، وحقيقه ذكر والتريتمنت الانهيلد ستيرويد. يمكن اكثر من مره احنا نطرح هذا الموضوع. حقيقه حضرتك ذكرت انه استخدام البكلوميثازون لحد العمر السنه، ممكن نستخدم الفلكسيتايد لحد عمر السنه. بالجينا بالنيلسون تكست بوك بالجينا ذني كلهم ينذكرن above 4 years. فاذا انا حقيقه انا يعني سألت الدكتور ايهاب على هذا الموضوع، انه اكو بالجايد لاينز عندنا يعني ايرلند بريتش جايد لاينز موجوده في شيء دوكيومنتد، يعني عندهم انه استخدام الاي سي اس انهيلد كورتيكوستيرويد بهذا الايج.
Locally it will be the same. If you look to the BNF, it will give you the same, like flexitide shouldn't be used below 4 years.
Yes.
And beclomethasone is the only option. But from our experience, and consensus, let's say with the Irish and English people, and from experience here, we're using this. Definitely, you're right. If you look for GINA guidelines or even the BNF, which is used here in Ireland and UK, they will give more restriction on those. But it's clearly we're using this for our patients. The beclomethasone, even use it from 6 months onward. The flexitide from 1 year onward, and so on, just like I mentioned the rest. The Australian, I found that the Australian guidelines is the only one you can find this answer clearly. So I would suggest even one of the things we can use it sometimes here. If you write like management of asthma, Melbourne Hospital. The Melbourne Hospital is for pediatrics, so you can find lots of really informative information. And one of them is this going to the age limit below the other guidelines. although it will be not strictly the same I'm mentioning, because this is from our experience and using those medications for a long time across the UK and Ireland. But you're right, we don't have written guidelines, and most of the time, even ourselves, when we prescribe medication, the pharmacist will call us back. No, this is not allowed, and we're telling them, no, this is our responsibility, and it's safe to be used in this age group.
شكرا حضرتك. بس عفوا سؤال ثاني على يعني in your practicing using biologic therapy، يعني هسه اللي تستخدم الأوماليزوماب والشنو in your practice؟
Here locally, mostly we will use the omalizumab and diplomat. It's basically just those two. One of them at the let's say beginning of the tree, which is the IgE, and the other one is a little bit high, because going high you make different pathways. So it's basically we're trying to start with omalizumab, and certain cases which won't work with that, we will go to diplomat. So otherwise, this is the practice here locally.
حقيقة سعيد جدا بمعرفتك، وأتمنى احنا نبقى يعني بلقاءات ثانية أخرى، وأترك المجال للدكتور علي صالح. شكرا جزيلا لحضرتك.
السلام عليكم. شكرا جزيلا دكتور على المحاضرة.
عليكم السلام ورحمة الله.
على المحاضرة القيمة، وطبعا أشكر يعني كل الزملاء اللي وفروا لي هاي الفرصة أن أكون بيناتكم. حقيقة أنا adult pulmonologist، أنا I am interventional pulmonologist، وأنا جيت من غير مستشفى، I just attend يعني يمكن على نص المحاضرة مالتك. حقيقة بس استمتعت بالبرزنتيشن وبأكيد بالدسكشن العلمي. Really I have two issues to raise. أول وحدة شغلة الإميون ثيرابي. I don't know if you know or not. إحنا بالمشكلة عندنا كبيرة، مشكلة الإميون ثيرابي. يعني it really practice here in a non خلينا نقول organized way. وأكثر من مرة أنا من كنت باللجان الاستشارية ويجي فكرة علاج immunity I try to have an evidence. ودائما أقول لهم دزوا لي a paper، دزوا لي study، and no one sent to me any paper to be evidence and sufficient enough to prescribe this medication. So my question, do you have a real well-established study and let's say guideline or concept to use this immune therapy in diagnosis and treatment and follow-up and doses and up-escalation and down-escalation? Because really in Iraq, up to my knowledge, we don't have. So do you have this issue?
Yeah, thank you so much for your question. Yeah, it's very valid, because we need to start on solid base. So I have a couple of articles which goes strongly about the benefits of those immune therapy. But if you're looking for something extensive, go into the indications, how to start, for how long, and what sort of parameters to follow. Yes, I can forward that to maybe Dr. Iyad, and he can forward it to the others. And even the biologics. I have a good article going to all those details of how to start, which to pick up, how to follow the patients, and all the necessary details you wanted. I can forward it to Dr. Iyad later on.
Okay, thank you. I will wait for that. Really, the second issue, as I told you, I am interventional pulmonologist. Usually in the adult, when we failed all medications, including 2 trials of biology, we are either to wait for TSLP, tislelizumab, or we proceed for bronchial thermoplasty. As you know, there's a big debate on the thermoplasty. Some say no. So you know that the catheter protection had been stopped. But I really I am one of from the persons that still believe in thermoplasty. So my question is, do you have used thermoplasty in below 12 years of age? And in your center, do you have thermoplasty, or you ever tried thermoplasty such above 6 to 12 years?
Thank you so much. It's a good question. Well, it's not just my center. It's across Ireland. Thermoplasty wasn't an option. It's not because it's not indication. No, it's still an option the guidelines, but we didn't have such a case of severe asthma, at least in the peds, because my specialty is pediatrics. Like I don't know on the adult side whether they are using this option or not. So I'm sure 100% for the pediatrics cohort here in Ireland, we didn't have any case required thermoplasty.
Okay, thank you very much, and really, it's nice to meet you. Thank you.
Thank you, Dr. Aamir. Does anyone of audience have question? Dr. Hussein Muhaibis from Karbala.
السلام عليكم دكتور عامر، شكرا جزيلا على المحاضرة. أنا دكتور حسين، أخصائي أطفال من المستشفى الهندية، حاليا متقاعد. سؤالي، إذا الطفل عنده allergic rhinitis إيش نستخدم ويا هو أسمى؟ إيش نستخدم له يعني كانتستامين أو مثلا نقدر نعطيه كيتوفين شيء من هذا القبيل على مود نعالج allergic rhinitis مالته؟ شكرا جزيلا.
It's very good question. Actually, one of my suggestions for Dr. Iyad, because I know allergic rhinitis is another bothering subject and needs to clarify, and definitely it will have the same classification of mild, moderate, severe, intermittent, or persistent symptoms. So using the antihistamine or using the inhaled steroid for treating the allergic rhinitis, it depends on the symptom severity. So it's usually if it is mild symptoms, just runny nose, not bothering, or even like just simple sneezing, yes, you're justified to use the antihistamine. And mostly we're using here the non-sedative one, the cetirizine. And we try it, like give a trial for a couple of weeks. If it didn't make any difference, the next step will be switching to nasal steroid and titrate the doses. Usually we'll start with Nasonex because it can be used like from 2 years onward. And if not, maybe we can switch later on to Avamys nasal spray, which is from 5 to 6 years onward. And the other option is a combination of nasal steroid with antihistamine, and we have two medications at the moment with Dymista. The Dymista is a combination of both, and there is the Ryaltris, which is again another combination of antihistamine and steroids. And sometimes the trick here for asthma management or hay fever, if you picked up a certain medication and it didn't work, you can switch to a different one. And we saw this in the past very clearly. Patient won't respond to X treatment, you switch to B, and he will be fine. So this is another option. Switching the treatment sometimes will achieve the control. So I would suggest cetirizine can be used, and if there is no response or partial response, so you switch to nasal steroid. But the nasal steroid, again, it's not just pick up the nasal steroid and use it. The technique is very important. So first, cleaning the nostrils with either saline or plain water, and then mild deflection, pushing the nasal sprayer inside the nostrils, and should point to the ears rather than to the eyes or to the nostrils, is very crucial in delivering the medication in the right way. So most of the time, even here locally, some of the GPs, they won't tell the exact technique for using the nasal steroid, and at the end of the day, there will be no response.
شكرا جزيلا دكتور عمر for your nice presentation. I would like to, what are the most clear distinction between the eosinophilic asthma and the neutrophilic asthma type 2, which is resistant for steroid, laboratory or clinical?
Yeah, it's a very good question. It's basically here we're talking about you have to do a bronchoscopy to discover that, because in the lab you can't diagnose it. You may have the F.B.C, but even the F.B.C as a sensitivity, it won't be just like the sputum or let's say the eosinophil. You can detect sputum eosinophil, and in children, especially below 5, although most of the time we'll try to avoid doing a bronchoscopy, and most of the time they will respond to steroid. But in general, using this in children, is very rarely in severe cases not responding. We may need to do endotyping, so bronchoscopy, and then according to bronchoscopy and bronchial alveolar lavage, we can see if this is a predominant eosinophils or neutrophils, because this will reflect later on in the management.
Thank you very much دكتور عامر قيس. اليوم انت معزوم على جيمر الحلة بس مع الاسف تفصلنا تفصلنا المسافات. شكرا جزيلا. Thank you very much for sharing your expertise, and we hope to repeat this webinar in the future and choose a further common problem so that we will enhance teaching here in Babylon. Thank you very much.